And it's just a huge honor for me today to be podcast interviewing Dr. Prabu Raman, DDS, MICCMO, LVIM, FACD. This guy is a legend. He's practiced dentistry in Kansas City since 1983. He's an alumnus of William Jewell College for undergrad, UMKC Dental School, class of 83, the Las Vegas Institute of Advanced Dental Studies, where he served as clinical instructor and featured speaker. He currently teaches lectures on live patient courses on aesthetics and TMD treatments sponsored by Myotronics, manufacturer of bioelectronic instrumentation for neuromuscular dentistry. His Kansas City practice, the Raman Center for Advanced Dentistry, focuses on 4 areas of excellence: neuromuscular dentistry, temporomandibular dysfunction, aesthetic dentistry, complex restorative dentistry, neuromuscular functional orthodontics, and sleep-breathing disorders, oral appliance therapy. He has achieved Mastership status of the International College of Craniomandibular Orthopedics and Mastership of Las Vegas Institute of Advanced Dental Studies. He is also a fellow of the American College of Dentists and a fellow of Pierre Fauchard Academy. Dr. Raman has lectured on TMD in Argentina, Australia, Canada, Germany, Italy, Japan, Russia, and the USA. He was selected by the American Dental Association Council on Scientific Affairs as a TMD expert to participate in the Science Forum at 2011 ADA annual meeting. He was also selected by the Journal of the California Dental Association to be invited author to contribute to its August 2014 TMD issue. Dr. Raman currently serves as president of the Missouri Dental Association, as a delegate to the ADA House of Delegates, member of the ADA Council on Dental Education Licensure, chair of Recognition of Dental Specialties and Interest Areas in General Dentistry Committee. He is also the vice president of the International College of Craniomandibular Orthopedics, past president of the International Association for Comprehensive Aesthetics, and past president of Greater Kansas City Dental Society. His other memberships include International Association for Orthodontics, American Academy of Craniofacial Pain, and American Academy of Sleep Medicine. By God, you are amazing. And you said you showed up here from India at age 20 with only $5 in your pocket, and look what you've accomplished.
I have a little more than 5 in my pocket now.
Yeah, are you up to a $10 bill now?
Yeah, somewhere in there.
And you also, you said the Missouri Dental Association is 151 years old, you said?
Yes, sir.
And you're the president, and you're the first president who wasn't born in the United States and non-white. Congratulations on that. I think that you just made my day telling me that.
Thank you.
I mean, this entire country was completely built on immigration. I mean, that's all it was. And it seems like every time, I mean, you look at the, I have a list that I follow of the Fortune 500 companies that were built by a first or second generation immigrant. And it's half the list. And if you're born in America, you're not hungry enough to do what it takes to start a great company like that. I mean, Google, Sergey Brin, Russian. I mean, the list just goes on and on. eBay, all these guys. So congratulations. Thank you for immigrating to the United States and for all your accomplishments. So there's so many things that we can talk about today, but I want to start with the 4,000-pound elephant in the room that no one ever wants to talk about. If I interviewed 100 endodontists, they'd hardly disagree on anything. If I interviewed 100 pediatric dentists on a chrome steel crown, there probably wouldn't even be an argument. My God, if I interviewed 100 people in TMJ, every single one of them would have a different thought. Why is it? Do you agree with that? It's almost like TMJ or TMD is almost like a religion, whereas a root canal is more just physics and biology. Do you agree with that or disagree with that?
No, I totally agree with you. And that is the reason why the California Dental Association had that issue that was referenced earlier, because there's so much confusion, so many differences of opinion, and it's confusing for dentists. What do you do? And one of the things that I think I alluded to earlier, I think you mentioned about how I talk about TMJ, what I did not learn in dental school. And you and I went to the same school, and unfortunately, they are still teaching the same thing, Harvard, what they taught us way back when. And some of those things simply are not true. And yes, there is this aspect of what do you believe, but it really shouldn't be. It all should be scientifically based. And more importantly, what works? What is bottom line? Do you keep exchanging paper versus paper and all those kind of things. Clinical dentists don't care. They're kind of like, hey, what can I do to help my patients? What can I do it in a predictable way? This is not going to be something so esoteric. Only a certain people can know how to do this. This whole idea of romancing the mandible, you have to have this touch or else you can't do it. No, if I can't do it, anybody can do it. It's a teachable thing. But this California Dental Association journal picked 4 people. And what is very unique about that particular one was this. Before, they wanted to pick 4 experts, and the deal was the other 3 will get to read your paper. Not like the usual stuff where you send it off, you don't know who's reading it, it's all anonymous. I mean, I'm a reviewer myself for a peer-reviewed journal. I don't know whose paper I'm reading. They don't know who's reading theirs. That is usual case. This one is pretty open and transparent. So the deal was they will get to read it. Other 3 experts, they know the stuff. They get to critique mine. I get to critique theirs. And then we get to respond one time. And there was so many words we had to use, like economizing the words. It was a great little concept. We were respectful of each other. We respect each other. But we were able to critique each other's paper and then got to respond one time. And they got a reward for that. So if somebody looks it up on that California Dental Association journal,
what year was that? That was
2014, I think. 2014.
2014. That is a very pioneering journalistic method.
Yeah, they got an award for that. It'll be excellent for any controversial subject, free and open. And I have done debates and so on, but that was much better. And one of the things I want to point out was I didn't spend too much of my time talking about my paper or your paper. I actually showed real examples. Talk about how is it done? One of the things I always say is, where the rubber meets the road, can you get the patients better predictably? And if you can't do that, then you need to kind of pay attention to that one. And that's all I do every day. That's all I've done for a couple of decades now. And if I must be doing right for me to be continuing to do this every day.
One of the things, if I really want you to go to his website, midwestheadaches.com, midwestheadaches.com, because your website is amazing. First of all, you have a YouTube video of a patient who's telling you that she had migraines and TMJ for 5 years. And when I go to a dentist's website, you're lucky that there's even a picture of the dentist, and usually it looks like a mugshot, for being arrested. And here you have beautiful smiling faces, your beautiful face, but you have a video of a human patient telling you their pain. So, you must have a very busy practice, and I give you an A. I give you an A+ on your website. And so many of these people that have problems, and they're not going to the yellow pages that you and I grew up with in the 80s. They're going to YouTube. They're going to Google, and they see 5 people with treating TMJ, and just nothing, mugshot. Then they go to your site, and you get to see live patient testimonial videos. So kudos to you on that. So what would you tell someone who watched these testimonials of these people in pain and were in pain for 5 years, and you're getting out of pain? How do they? Let's just start one by one. How do they learn more about your 4 areas of excellence? Let's start with just neuromuscular dentistry, temporomandibular dysfunction. How does someone learn more about that? What should they need to know about that?
You mean what is neuromuscular dentistry? Is that what you're asking?
Yeah, and temporomandibular dysfunction. Yeah,
a great question. Basically this, when we were taught in dental school, and they are still teaching these days, TMJ meaning the joint, right? Joint good, joint bad. As a matter of fact, if the jaw joint didn't pop and click and hurt, you don't have TMJ. Well, that's not the whole story. The analogy that I often use to explain to people is this. Say if you go to a hotel room, you try to close the door. The door is just a little bit off. It doesn't quite close it right. How would you shut it all the way? Shove it, right? Hard. Once it is slammed hard and shoved into place, would anyone say it's a perfectly fitting door? No, it's not. It's been shoved in. If you keep shoving it in long enough, thousands of times a day, what will happen to the hinges over time? Come apart, get loose, got to get stuck, get out of track, any of those things, right? When that happens, now we have a hinge problem, right? Well, let's look at this analogy of the jaw. Upper jaw is like a door frame, lower jaw is like a door. What moves it is the muscles. No matter what happens, the jaw muscles, controlled by the jaw nerves, of course, will get the teeth to come together so we can put your teeth together, chew and eat and function and live. Well, that's what we call occlusion. Occlusion is nothing more than where the teeth fit. The teeth fit is where the door has been shoved in, so to speak. Well, no one will say that it's ideal, but do people get away with it? Absolutely. We have a lot of adaptive capacity. That's a good thing. Otherwise, we can't do dental work. So a lot of people get away with it in the sense they manage to use the nerves, control the muscles, neuromuscular, that's where the neuromuscular comes from, get the teeth to come together, jaw muscles pull them in, so the teeth fit together. Yeah, I can chew and eat. Matter of fact, where do we keep the jaw? Most of the time, close to striking distance, pretty close to where the teeth fit. We call them a freeway space, 1 or 2 millimeters away from where they touch. We're not going to stay way over here and come back a couple of thousand times a day. We're going to keep them close. If you do it all day long, what happens to the muscles? They're going to get tired, fatigued. Do they all have pain? Not necessarily. But a lot of times people get away with it because they have adaptive capacity. When you get over that one, when you no longer are within your adaptive capacity, now we have symptom. Now we have pain. Most of the pain does come from the muscles. We call them myogenous TMD, but it is all the same. Temporomandibular dysfunction just means things are not fitting right. They're not functioning properly. The term that I really use, I like to use better, it's not very common, is craniocervical mandibular dysfunction, CCMD. It hasn't taken off yet because it's a longer one, because what happens to the jaw affects the neck. You really can't ignore that one.
Say it again, what does CCMD stand for?
Craniocervical, head and neck, mandibular dysfunction. It's actually a more accurate term. But TMD works because, that's more commonly known. TMJ is a little too narrow. It's just a joint.
But the sad thing about the terminology is with the people, the patients, they have already branded it TMJ and root canals. And then the dentists want to say, no, it's TMD and endodontic therapy. But it's kind of like it's too late, we're behind the 8 ball because they call it TMJ and root canals.
Quite okay. It's just a way of communicating, right?
Right.
I mean, it's like saying I have a knee, but knowing, well, I have a knee problem, right? So I get it. But one thing that people do make a comment of is, how come your website says Midwest headaches? How come it doesn't say Midwest TMJ? How come it doesn't say Kansas City TMJ? Well, the answer is very simple this, and I'll give a credit to my wife for that one. She says, people don't know why they have a problem, but they know what they're experiencing, right? If you have a headache, you know you have a headache. You don't know where that is coming from. By the way, headache is probably the number 1 symptom of poorly aligned jaw. Number 2 may be neck. Number 3 may be ear pain. Those are the top 3. None of them directly to do with the teeth, are they? So we picked the term Midwest headaches because I was thinking big in those days, all the way around Midwest instead of saying Kansas City, which is funny. It's almost like, I'm sure you know the story about IBM, the guy that came up with the IBM name, International Business Machines, way back when. They just have adding machines. He was thinking big. So I was thinking Midwest headaches, thinking all around Midwest. But in fact, I have treated people from pretty much all over the U.S., currently treating a kid all the way from Texas and New Orleans and so on, also from overseas. But that is why we came up with the Midwest headaches. And she was also, will give her the credit for how that is organized. When you go to the homepage, it has all the symptoms. People go there for one reason. They go, oh, I have that too. I have that too. And they click on it and they learn more about it. There are a few case histories. So my primary purpose really, Howard, is to be a source of good information. Whether they come to me or not, I don't really care. But it really is important for me that they get good information. You mentioned about going to Australia. I have lectured there before also. I had a couple of emails, I think maybe last year or so. One woman saying, thank goodness I ran into your website. I'm not crazy. I have all these symptoms. Do you know somebody in this area? I sent her somebody there. Then a week or so later from Sydney, this other lady's very similar email that's saying, I'm not crazy. I'm feeling all these. Do you know somebody? I know 2 people, Brett Taylor and Fred Calawasi. I said, gave him 2 names. So my purpose is to just be a good source of information. So they go to somebody they can really get help, because way too often they get their own around.
You know, you just had 6,000 American dentists graduate last month. And one of the first questions they ask on Dental Town is, I want to learn more about occlusion. And it seems like there's two main camps of occlusion, CR and neuromuscular. Does it matter which camp they go to? What is the difference between CR and neuromuscular? Do you really think they need to pick a camp first, or just start learning all they can about occlusion?
Well, let me be blunt about it. As a matter of fact, I wrote something for Dental Town years ago called Occlusion Confusion. It was published on Dental Town because I was giving a course.
Can you find that link? Occlusion Confusion. That sounds awesome. It was
on Dental Town a few years ago. And I kind of compared the various philosophies. And one of the reasons why I don't think it's such a great idea to have a TMD specialty is this. It's a fundamental philosophy. How does it all work, right? Because that has to be an underlying philosophy for the whole thing, no matter what you do. So, so to answer your question, I think it absolutely makes difference which paradigm that you want to use. Paradigm is a model, right? How does it all work? So I talked in simple terms about a door and a door hinge and all that. So a CR, let's be honest about it, it's all about joints. I have actually treated people that have a crappy joint or hardly any joint at all. So where does the CR come in? So if the philosophy is based on a joint position, they can argue about where that should be. Used to be up and back, then up, now down and forward, whatever that might be, it doesn't matter. But this is a bigger one. In other words, look at the nerves, look at the muscles, the physiology of how things move in the jaw is not much different from any other part of the body, right? That is like a fundamental way of how we function. So to me, I have absolutely no doubt. I think this makes more sense. And one of the questions one of my favorite quotes is from Thomas Jefferson, that said something that I'm paraphrasing probably, something to the effect of question everything. Question everything. Even if it is the existence of God, question that one. If there be a God, the God will probably more appreciate the fact that you're questioning, and rather than just going by blind faith or something. So by all means, question. If it doesn't make sense, ask people.
So if someone wanted to learn about neuromuscular dentistry, where would you send them?
Well, I teach them, and other people that teach for Myotronics, and they can look through Myotronics, but that is the.
I mean, do you teach over the shoulders at your office, or how would they learn from you?
The first step would be probably is a introductory course, 2 days, and I teach some, and Dr. Mike Miyazaki teaches a lot of those too, and that is usually in a hotel location because you don't need a clinic for that.
How would they find out where those courses are?
Go to myotronics.com.
Myotronics.com.
And it's on the first page. I think they show their CE offerings. That'll be a good place to start.
And how much is that machine these days?
Which machine?
The Myotronics machine where you measure the bite.
Okay. There's several. Probably the very basic one to start with, which would be the principle behind getting the jaw in the right place is they use the term Myo Monitor. It is an ultra low frequency tense, and that's all you basically need to begin with. That one is like a couple of $1,000s, not much.
How much?
About 2,000 or so. I don't know the exact number. I think it's about.
Yes, and so if you go to myotronics.com, you can see Series 1, Series 2 of where these are at. There's a course coming up in Los Angeles, Calgary, and then you're teaching one in Kansas City, September 14, and it says September 14 to 16, so that's a 3-day course. And then October 5 to 7. So that's nice. And then you'll also be in Seattle, then Washington D.C. So go to myotronics.com. But you say
that's the place to start.
That's where you recommend they start. Yeah. And the basic machine you say is only how much money?
About $2,500, something like that. I don't know the exact number. It's not very much. Okay. But I think you may be referring to the K7 computer. That is a more expensive one. And let me address that a little bit, because sometimes people think it's all about selling machines. It's all about expensive stuff before you ever get in. And there was a criticism some time ago, oh, you don't need all of that. Why do you need all that expense? Heck, I spent my first iCat machine. That's like pretty near $200,000 in 2000. And people buy the CEREC machines and similar machines. Don't give me a big grief about something that costs maybe $30,000 or so. But my point is, don't jump there. You don't need it. The analogy that I use, I'm not a pilot. Are you a pilot, Howard?
No.
Okay.
I was going to be, but when I found out that you can't drink beer while you fly, I said,
there you go. No, my point is, on clear weather, most pilots are just going by visual flight rules. They can see where they're going. They fly for fun or whatnot, right? But when you get to something a little more complicated, go over the mountains or something, everything is upside down, you don't know where they are, then you need all the avionics. Then you also need to know how to read it, right? That's kind of what the K7 machine is. You don't need there unless for those cases, like I use it every day. I have 3 of these. But my point is, you don't need to jump in there and spend all that money. Start off with, does it make sense to you? Go to one of these courses. Does it make sense? It has to. That is, don't ever go by faith. It has to make sense, and then start off with something like an ultra-low frequency TENS machine. Learn how to do it. You'll do it in the first course. Go home and try it out. That is how I started way back when.
Well, what I want to do is, again, the online CE is mostly millennials, guys like you. Like for me, if I want to learn the most information in the shortest amount of time, I always read a book. I mean, a textbook, a dental textbook. I mean, you'll watch some program on TV and it'll be say it's on the Great Barrier Reef, and it's like you can watch an hour program and only write down like maybe 3 things you learn. But if you got a textbook on the Great Barrier Reef by a PhD, in the same hour of reading, you would have had 4 pages of notes. And but the millennials like podcasts and online CE. So you're talking to a bunch of kids, and here's what I want you. Here's the specific question. Some patients are all fine, and then you do something as little as just like a single unit crown, or you just did 1 filling, and you just set off the whole damn thing. How can you keep these young kids out of trouble? What's the low-hanging fruit so they don't think, oh, a broke tooth crown, no big deal. Now they've thrown someone all the way into TMD and all that.
It's a wonderful question. That's exactly what I'm going to be talking about in this program I'm going to do at ADA.
And you're going to put it online on Dental Town. Put the lecture online.
Heck, I can do it before that. All that I really care about is to get this information out. My point is this. You don't see what you don't know. Would you agree with that statement?
Absolutely.
Right. The biggest part is really learning enough you don't even need to teach this. You don't need to choose to do it all the time. Learn enough to recognize a problem when it walks in. Oh, this isn't good. If nothing else, a good conversation can happen. You could be, hey, I see lots of signs. Things aren't quite okay. That is you have signs, but not really symptoms. They're saying, I don't have any symptom. I don't have any pain. What you talking about? I'm good. That's fine, but I see all these signs, and I could at least inform you of it. Hey, things are not okay. They could say, I don't care, doc. Just fix this crown, okay? Then you would have at least had them informed, have an informed consent, say, I have done given the information, okay? The other thing that could happen would be, when this conversation happens, oh, as a matter of fact, I have lots of symptoms. I've been going to this doctor. I'm going to that doctor. I'm going to a neurologist. I'm going to the ear, nose, and throat. It happens. Then they could say, you know what? You may want to go to somebody like me that go here and check it out. And maybe they'll thank you for sending them the right way. That could happen. The other thing would be people that they don't have symptoms all the time, once in a while. Well, I just have it occasionally. Then I'm good otherwise. Then there are people that are all the time, persistent TMD. They're actually, think of it like a pyramid. The bottom is lots of signs. If you know enough, you can see it. If you don't see it, you're going right by it. An analogy that I use is you and I go to a crime scene, we don't see it. An investigator or a crime scene investigator find these little bitty things that are clues for them. That's all I'm talking about, showing the signs, learn enough about the signs to recognize. That's the first one. They're the people that are subclinical TMD. There are signs, but no symptoms yet. The next level is transient, once in a while. If I do this, if I overdo this, then I have pain. Otherwise, I'm good. The third will be persistent TMD. Those are stages, if you would. And this whole idea of adaptive capacity, what your body will put up with. Oftentimes, they're right about the edge. They don't know it, you don't know it, you do something, everything blows up, and now it's on you, right? That is really what I would like to avoid for dentists. And I have seen cases, simple as a single filling, single crown, or lumineers. That's not supposed to change your bite. Or orthodontics just barely started. Of course, the orthodontist says there's absolutely no way that could have cost it. Well, he's right in a way, saying he must have done thousands of cases. They don't cost it, so it cannot be it. But my point is, it's like the straw that breaks the camel's back. That last straw didn't do it, but the last straw gets too much credit or too much blame, depending on how you look at it. So to answer your question, the way to start would be learn enough about it, learn the signs, what all to look for, and the first course would be enough to do it. And maybe we'll put on a course with you, what all to look for, so that you recognize it like, whoa, 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 something isn't quite right, and have a conversation. And if you have a conversation, the patient were to choose to say, I'm cool with it, leave it alone, and if you choose to go, that's okay. At least you would have been informed. And this analogy is not so weird. Think of it like a heart problem. There are a lot of people walking around with half of their coronary artery closed up. They don't know it, right? And these are also people that have coronary arteries 80% blocked up. The only time they have a problem is to go up about 4 flights of stairs. Otherwise, they're good. Then you have somebody who had a full-blown heart attack. Did that happen overnight? No. It's been going on for a while. Unless you do some tests, you will never know. That's kind of what the K7 computer that I talked about is useful for. I can actually measure things. And that doesn't mean everybody needs to have it, but we do have the technology to be able to measure that. And yes, this technology has been approved forever. I know there are people saying, oh, you don't need all that and all that. No, you don't need it. It's just like saying you don't need all the avionics in a airplane. Yeah, you're right. There are planes that don't have any of that. But you better not be taking cross-country flights on that one, right? You might get in trouble.
Yeah, you should have talked to the Kennedy son before he took a night flight.
Exactly.
You know?
You got it. Yeah.
Yeah.
And not only have the machine, know how to interpret it and use it too, right? That's also important.
So that was a great. So aesthetic dentistry, complex restorative dentistry. How do they learn more about aesthetic dentistry, complex restorative dentistry?
Well, the second course we did talk about the smile design, how to do that, and all that,
one
and
was
more
the
importantly,
prep course. Then one was the seat date.
Yeah, and the idea there is, you want to have the functional part, and you also want the pretty teeth. You can have both. It's not either or. And more importantly, it's really, really important for people that do aesthetic dentistry, veneers, and so on, to know enough about it. They don't make people that used to be symptom-free, put them into symptoms. I often used to tell people, if somebody coming to me with disabling symptoms, if I get half of them better, they're happy, right? They're better than they used to be. What if somebody walks in, they absolutely have no symptoms at all, but then after some treatment, they have symptoms? They have every right to blame you, right? They're like, I was perfectly fine until you did X, Y, Z. So it is, in a way, even more important to learn what to avoid, if you will. What are those things that are waiting to blow up on you, in a way.
So I'm gonna. This is Dentistry Uncensored. I don't like to talk about anything everyone agrees on. So
okay.
Now I'm gonna get you in trouble. So I'm gonna throw you under a bus right now.
Go right ahead.
A lot of dentists, when they're learning TMJ or TMD and occlusion, they're very confused because they say, look, we send so many millions of American children through the orthodontist, and they're pulling first bicuspids and wisdom teeth. They're leveling out the curve of Speed, the curve of Wilson, and when the kid's done with the orthodontics, they don't even think the kid's occlusion was finished off. Do you think orthodontists, there's over 10,000 orthodontists in America. Do you think they do a good job with occlusion? Do you think it's more of a mass mill and they have this very adaptive capacity and it just works for most kids and doesn't work for a few? Or what's your general rant assessment of the American orthodontic factory that we all send our children through?
You did say you were going to throw me under the bus, didn't you? You're not kidding. No, I have. Let me back up and see what do orthodontists do most of the time? Give you pretty teeth, straight teeth, nice looking front teeth, right? If that is your goal, they do a great job. You know, do they do a good, efficient job of doing it and get people nice straight teeth? Absolutely, yes. That happens, right? The other thing is also true. 4 out of 5 people that I meet have had braces before. They often have been complimented on the nice looking teeth, nice looking occlusion, meaning where the back teeth fit. Now, this may be a time for me to bring up a story, which I thought you might ask, why the hell did I get into this TMD business? Why? Because I was making a nice living. I had 6 ops, 8 people working for me, making more money than I am now. But this is why. Back when I was right after I was out of dental school, I took my own wife to a local orthodontist. A good guy, wanted to have straight teeth. You went to UMKC. How much did you know about orthodontics when you came out? Not a whole lot.
0.000.
You got that right.
And when I asked my instructors, you know, are we going to learn anything about ortho? He said, Howard, if you want to learn anything about orthodontics, you need to go to ortho school. And I thought, well, half the class is going back to rural Kansas and Missouri where they don't even have a specialist.
Yeah.
I mean, yeah, anyway.
Yeah. The same school I went to. I had similar kind of experience as well. So I didn't know anything. So I took her to a local orthodontist. Now that I know what I know, that would have been an easy case. I didn't know. So one of the first things he did was, when you get 4 bicuspids, but she had minimal crowding in the front. That's about it. I have an old picture of her somewhere. But I followed the advice, had 4 bicuspids taken off. I didn't want to do it because it's my own wife. I hung on to her hand, took her to a surgeon, IV sedation to get that taken out, and a wisdom tooth. And everything was cool. As she was getting towards the finishing part of her orthodontic treatment, she became a migraine patient. And we took her to the physician. They said, oh, she has migraine. There's a medicine. I think it was at that time some kind of triptan medicine. And she couldn't tolerate it. And she would only take it if she couldn't take it anymore. It is so bad. And she's from Korea. And there's a whole story there about how she left. She defied her family to marry me. They disowned her. And yet I'm doing this to her. I felt so guilty. So I knew I'm going to find a solution for this. I just did not believe the physicians. This migraine is a coincidence during braces. So that is really where I started learning. I started learning with the John Witzig. You know, he's passed away. That's one of my first forays into this. He was talking about functional orthodontics, made a lot of sense. Then I took a whole lot of courses with Jay Gerber. That is really where I started. And that is where I learned about neuromuscular dentistry. This aesthetic part came later. So now I do both. But to answer your original question, do all orthodontists harm patients? No, that's not a fair thing to say. It's a very, very broad stroke. Do they do sometimes treatment that puts people on their path to have more problems? Absolutely. Absolutely. It happens all the time. Because 4 out of 5 people that I treat have had braces before. Some of these people have had more than once. Many of these people had braces specifically to have a better bite. And I have also had referrals from orthodontists. One orthodontist, a couple of years ago, I had a call from her. A patient said, so this orthodontist referred. So I called her, say, thank you. You should call the referring doctor. About half of our patients come from internet, half from other doctors that refer. I don't do any other advertisement kind of thing. So I called and asked her to thank her. She goes, she's not really my patient. Oh, she's not? It says here, you referred. Oh, I referred. She came to me for third opinion. I said, really? Yeah, she's been to 2 other orthodontists. She has a perfect bite, perfect teeth. The last orthodontist I made her splint her bite guard. But this girl has a lot of jaw pain. I don't know what to improve. She has a perfect bite, perfect teeth. Maybe you can help her. So I referred her to you. So this girl comes in. I usually call people before I meet them. So started asking questions and so on. I asked her, this is the way I ask a question, which is an odd way to ask. If you could have any health-related outcome, anything at all, just like a genius wish list, what would be number 1? She said, anything at all? I said, yeah. Migraine. I said, really? I thought you're coming for jaw pain. You said anything at all. I said, yeah, tell me about it. She's in her late 20s, an IT person. She's been on a migraine medicine since she was in 8th grade. She was on so much medications. Every time she calls a neurologist, they said, up the dose. I said, if I take any more dose, I can't function. I just put up with it. So if you could get rid of that, oh heck, I can put up with the jaw pain. What's your number two, Callie? It's her name. Neck pain. I have a lot of neck pain. I said, okay. What's your number three? I have shoulder pain, upper back pain. Number five was jaw pain. That is, she thought she's coming to me to see jaw pain, but really that turned out to be number five, and she had many more too. The interesting story was, even though her teeth looked pretty, the bite looked good, they're all interdigitated, they were in the wrong place. Those muscles were constantly working. Once I figured this out, put where the jaw should be, literally within a few weeks, all of her symptoms went away, including her jaw pain, off the migraine medications. Now she's married, she's having a baby, she's pregnant right now with a young husband. All of those could not have happened, I don't think, if she's still with migraine, taking all those medications. So that's what the cool part about this one is. Back to connecting orthodontics and so on, not all orthodontics cause problems. Many of them inadvertently do. They are straightening out the teeth at the cost of function. If you don't look at the muscles, if you don't know how everything else lines up, sometimes you get it right, many times you don't, and the patient don't have problems until much later. So they often don't connect it. So am I under the bus completely, or semi under the bus?
Nice answer, but I got to go back. So did you meet your Korean wife in Kansas City, or did you meet her in Korea?
No, meet her at the school, William Jewell College in Liberty.
Oh,
she came,
in undergrad.
Undergrad. She came here. She's supposed to go back home, and I was from California. I was supposed to come here and go right back to California. We met, and my family didn't like that idea. Her family didn't like that idea. They all had different plans. So they both disowned us. And she would not go. She never did listen to me even then. I said, you know what? Maybe you should marry the doctor that they picked for you. He said, nope. And so that is 40 years ago. We've been married 40 years now.
So who had picked it up? Who had the arranged marriage set up? Your wife did? They wanted her to come back to Korea?
Yeah, they wanted her to come back to Korea. As a matter of fact,
did they have an arranged marriage for her?
Not arranged so much, but try to find a match. There's a nice doctor in, I think it's Louisiana or somewhere, Korean background, and well-to-do family. They were looking for a nice Korean girl, but the son wanted somebody that is new America. The kid was already going to school. This is perfect. They all thought it was perfect. She didn't want to. And my family wanted to marry a nice Indian girl. Neither did I. So here we are.
So what did your wife end up becoming?
How do you mean? Oh, she's an accountant.
An accountant. Very nice. Yeah, it's funny because I'm a product of bringing a family back together. My dad and mom's families disowned them because my mom was Irish Catholic and my dad was, his family was Episcopalians. And I guess back in the late 30s, the lowest thing you could do in Kansas is marry an Irish Catholic. And they disowned them. So then they got married. They had two daughters, my two older sisters, and still no communication. But then when they had their firstborn son, me, that's when the grandpas, they wanted to see their firstborn son, and that was the icebreaker to get them back together. I thought
it's so. We can imagine in your case, to me, from my perspective, that should not be a problem, right? But obviously, it's a big problem in their culture, and you can imagine two different countries and two different cultures and so on. They just, oh no, I can't do that. And here, we had three beautiful girls, daughters, and heck, we're going to be grandparents this December. Our first.
Right on. Congratulations. So I want to ask you another extremely controversial question.
Please do.
Pharmacology.
Okay.
Some TMJ people, TMD people use a lot of pharmacology, and other people don't think there's a place for it and think it's more mechanical and do your treatment. So what are your views on pharmacology? No matter what you say, half the people listening will disagree with you.
Well, I get it. But let's talk about pharmacology here. Most of the medical world lives on pharmacology, right? That's where billions of dollars are made, right? So pharmacology, if you can think in terms of the adaptive capacity, I often use a cup analogy. I like analogies if you haven't heard it already. If you have a cup, lots of things fill it up. How the jaw fits there 24/7, how the neck and the posture fits there. That's where the airway comes in. If the airway isn't good, you're trying to make up for it. The neck is forward, the back is messed up, posture is bad. On top of that, you have biochemistry, diet, medications, and so on. Or even for the hormone changes, they all are go on top of that. On top of that, if you can think of it, would be the stress. Comes and goes. We blame stress a lot. It is often the precipitating factor. So now back to your original question about this pharmacology. When you give a medicine, let's talk about migraine as an example. When you give a medicine, what are you really doing? You're finding some way of symptom relief, right? To me, it's almost like finding some way. Yeah, say you have a check engine light comes on a car. You're driving along. Most people will take the car to the dealership to figure out what's going on, find out what it is, diagnose it, and fix it. What if you could find a way to just reset the check engine light every 3-4 hours? Are you cool? No more symptoms. So that's kind of what pharmacology does most times. Then, of course, somebody else might even go to the next level. If I can find the wire that is coming to the little indicator light, man, that indicator light will be gone for good. There are some surgical procedures that are doing just that, cut off the nerve where the pain is coming from. To me, back off. Where's it really coming from? And see if you can figure that out. See if you can fix it. And this may be a good time for me to bring this up. I never tell anybody that I treat migraines. I never tell anybody I treat fibromyalgia. I never tell anybody I treat cervical dystonia, any of those things, because I'm very clear about what I do. I'm a dentist. What I'm good at is getting the jaw and neck alignment. I know exactly how to do that one right. So I very much follow the ADA parameters, the TMD parameters of care. But what I also know is when the jaw and neck are properly aligned, many of these symptoms go away. Like the girl I mentioned about Callie, a bunch more symptoms, including migraine, went away. But I'm very clear about what I'm doing. I'm doing well within my scope of practice, correcting the jaw alignment. By the way, always correct the jaw and neck. Back to your pharmacology, I'm okay with using pharmaceuticals as a short term, and I also use trigger point injections, again, as a short term. Those are all things to give some temporary relief while you're facing the real problem. As far as having that as a long-term solution, I don't think anything at all. I don't think, if somebody is set on it, I pretty much tell them I'm not the doctor for you. I'm more one of those, I say I'm not a pain management doctor, I'm a pain resolution doctor, depending on what you want.
Okay, I asked you to throw the orthodontists under a bridge and tell you what you thought of them. Now I'm going to throw my own homies under a bridge. I'm going to throw 95% of all the general dentists under a bridge. This is reality. I mean, this is total reality. In 95% of dental offices, when you come in and you tell them you have any of these symptoms, any TMD, anything going on, 95 out of 100 dentists just take upper and lower impressions, send it to the lab, make a night guard, and say you're cured. Agree or disagree?
That's not at all a bad way to start as a first step. What do you got to lose? It is a management strategy. Nothing wrong with that, right? You can manage or you can fix the problem. I'm not saying management is a bad one, but especially if you're using something like a medication that you could put in chemicals in your body forever and ever, that is worse than putting a piece of plastic. Again, if the person is more in the transient stage, meaning they have once in a while problem, put a piece of plastic so they can slide around in their nighttime and they're doing good afterwards, happy. What's wrong with that? That's a pretty conventional, very, conservative way of doing it, right? You're not really doing any harm. What's the worst thing you can do? Put a piece of plastic. It costs a few $100s for the patient if they're doing. But if that is the only tool you have in your toolbox, then I would have a problem with that. There are actual people. They're called. Again, you started talking about throwing me under the bus. I'm going to throw myself under one here. There are people that are orofacial pain specialists, and what do they really do? Let's get to the bottom line. What do they really do? They do a lot of diagnostic part. Fine, cool. Then what? Piece of plastic, what you already talked about. Wouldn't a second-year dental student know how to do that one? Do you really need a dental degree in a specialty to be able to put a piece of plastic? No, you don't. You can give a lot of medications. Well, do you really need a dentist to give medication? There are plenty of physicians, nurse practitioner give you medications. Or you can send them to psychological therapy. Oh, there are plenty of psychiatrists and psychologists. What do you really do? What do you do unique here, right? That's the kind of question I have for them. So back to the piece of plastic, nothing wrong with that. That is not a cure, it's a management strategy. And if the management is enough to get the patient get through their life, fine. Nothing wrong with that. So I don't really think I'd throw anybody under the bus on that one.
Another big scary thing that, again, I'm trying to aim this at these young millennials that are coming out. Sure. They might be getting to their first full mouth rehab case or a first big complex aesthetic case. And they've heard all these nightmares that you don't want to open the bite. If you open the bite, All hell's going to break loose. What's the story on opening a bite?
Okay, that's a very good question. Let me talk about what do we mean by opening the bite. What we're really talking about is opening the bite. They think in vertical, right? They're opening the bite so much. And how many thousands of dollars have you all spent on articulators? Thousands, right? I had a fully adjustable Danar, I had 2 Hanov and something else. I have a couple, 2 or 3 Stratus, bunch of thousands of dollars. Most of them based on this fundamental concept, if you would. One of those many lies that are taught to us. I'll use the word lie. First 20 millimeters, you're just opening as a pure hinge. Haven't you heard that? Didn't we learn all that? What else moves like that? Your articulator, nothing else, not a real person. So when we think in terms of vertical opening, how many opening, that's really a misnomer. If that were true, first 20 millimeters is more than enough for 2 teeth, right? Height-wise, more than enough. If that were true, why do they get this all done? Let them do whatever CR, whatever method they have to figure out where the bite should be, send them off to have the crown done, or multiple crowns. When they put them back in the mouth, how many of them don't adjust? They all adjust. Why? That doesn't exactly fit the same way. In the mouth doesn't chew the same way the articulator chewed. Note, because that is an absolute truth. That's not how it works. Let's go back to the joint. I have had a CT scanner since 2006. I'm on my second one now. So I have imaged every single patient that I treated, jaw joint. No 2 condyles are exactly the same, not a single 2. And there is no average. They're all over the place. So the jaw doesn't exactly open exactly the same on the left and right, let alone between people. So what it really means is we need to figure out how the jaw really functions. And, when I talk about the neuromuscular concept, relax the jaw muscles, neck muscles, figure out where that is. What you often find out is, I measure them every single case, by the way. Sometimes the front may open, say 4 millimeters, back is 4, 5 here. What does it happen? Jaw came almost straight down. So how would that work in an articulator? No, it doesn't. So you need to really figure out the physiology and so on. Back to your question about what would a person like that, a young dentist taking on a big case, probably the best advice I would give them would be very clear, you're not changing the bite. Because if you're changing the occlusion, changing the way things come together, then you better be very careful that you preserve it correctly. And if you're doing one, depending on why they're doing it, if they're doing it because a bunch of teeth are broken down, they need to fix them anyway, do them in stages so you're maintaining the best you can. So at least you didn't make them worse. Because 99% of the dentistry get done are on the presenting occlusion, right? They walk in with something, you do 1 tooth through 2 teeth or quadrant, whatever you do, then you don't really change them, hopefully. That's kind of what I'll talk about, hopefully, on this CE course we'll do for you. And then I'll also be talking about ADA, about what are some strategies you can use. So at least don't make the patient worse. So the whole thing about, above all else, don't do any harm to the patient, right? So if you can keep them from changing arbitrarily, then you're better off. The worst thing you can possibly do, I can tell you this much, open the pin 2 millimeters. On the articulator, it does happen. Wouldn't you agree?
Yes.
People do it. I need more room. Open. Where did I come up with that one? It absolutely has no relation to reality. And just opening like this, the only time it has any, only reason they do that is because we were taught in dental school, for the first 20 millimeters, it is all pure rotation. You can just open it up. Does it actually work in a real patient, live patient, as a first 20 millimeters in rotation? No, it doesn't. You can make them. I can actually grab them and make them rotate, but if they are actually moving on their own, rotation, translation, all happens simultaneously. A lot of studies to show that.
She's 25 years old. She's a 25-year-old dentist. She's working in corporate. She's working at Aspen.
Mm-hmm.
And
Okay.
the mom, she's doing a hygiene exam on a mom, and the mom says, my 3-year-old daughter sleeps with me in my bed at night, and she just grinds her teeth. You can hear it clear across the room. What should the dentist say how do you respond to that question when mom says that about a 3-year-old, a 4-year-old?
Yeah, a lot of times, by the way, the grinding like that happens because they have ear issues. They may have plugged up ears, and the eustachian tube, if it is plugged, when you clench and so on, move the jaw, it feels better. That's the reason why we chew gum on a plane, because the same nerve, trigeminal nerve, that controls the masseter, the medial pterygoid, there's a branch from the medial pterygoid going into the tensor veli palatini and tensor tympani. Tensor veli palatini is a little bitty muscle that controls the eustachian tube. So if it feels itchy, if it feels plugged, they grind so it feels better. So maybe what they need to do is to get them to the primary care or ENT to see what's going on. Maybe they have some kind of ear problems, allergy problems. That might be the reason they're grinding, not because a bite is off.
Okay, this one's an intra-office controversy.
Okay.
Abfractions. The hygienist is telling all your patients it's because you're sawing your toothbrush back and forth. And then the dentists are listening to veterinarians saying, hey, these animals out in the Serengeti, they have abfractions and they don't have toothbrushes.
Yep.
What causes abfractions?
Well, it is a flexure. It's basically bending. One of the things, I don't have it handy, one of the things I often show to people is when they have a lot of abfractions, it's a TMD patient coming to me, but they have had a bunch of composites right at the gum level, because every time they've been to the dentist, oh, you have one more to fix. Some of them are below the gum, and I always ask them, did you just brush that one tooth harder than the front teeth? Not really. And how many times do we see abfractions, Howard, that they go below the gum? And you have a tissue sitting here. Did they get the brush in there, brush it hard, but not touch the gum? Give me a break. And again, the hygienist, unfortunately, probably is repeating what she has heard or he has heard. But it is really from flexure, too much pressure on them. And if you get a roll of paper, little paper, roll it up, and bend it, put it in your hand, sticking out. If you bend it, it'll bend right where you're holding it, and immediately the patient's eyes open. Oh, that makes sense to me. It is a physics phenomena. It's too much pressure, biting. Clenchers more than grinders, by the way, tend to have more of an abfraction. And why do people clench? That'll be the next story.
Well, why do people clench?
Now that you asked, most people say clenching is because of stress. Stress does increase clenching, absolutely true. When you're getting ready to punch somebody, you're going to clench and stabilize your jaw before you throw a punch. So when you clench, it increases your stability temporarily. It's almost like holding on to something for more stability. People that have postural problems, not just the jaw connects to the neck connects to the rest of the body. One of the many things that I check when I meet somebody for the first time, check their posture, check their gait when they're walking up and down, how are they, and so on. If there's a lot of problems with that, I don't fix anything below the neck. My area of expertise is right here. My license is right here. So I'm very clear about it, but I'm aware of the rest of it. To see if things are not okay, which one came first? I can do a balance test easily, and I'll show that when we do the CE course for Dental Town. It is easy to do that one to see where that might be coming from. What we find out is a large number of them, not all of them, large number of them is because poorly aligned jaw. If the jaw is poorly aligned, it affects the neck, it affects the whole thing. And why would this be the first one? Why is this so important? The jaw is the right place. It is one end of the postural chain, right? Bottom of the foot all the way to the head. It is one end of the chain, but this chain is more important than the other end, because this is the end we feed, we breathe. This is a really important end, top end. So no matter where the jaw fits, it will come together so we can chew, eat, and live and all that other stuff. And if you need more airway, bring your neck forward. We'll do all that. But there's a price to pay. So people that have poor jaw alignment oftentimes have a postural alignment problem. When they have a postural alignment problem, oftentimes they clench. So we had to find out why. And there's some, we're not going to make them all perfect. If you can get rid of the original problem, if that is the case, then, doing things like physical therapy, yoga, those are all good strategies long-term to maintain.
Okay, now I'm going to, more controversies, more throwing you under a bridge.
Okay.
I mean, again, these are millennials listening, and she's hearing some pretty outlandish claims, and some of this stuff is on Dental Town, that there are people who do sleep apnea, sleep breathing disorders, that say that it is absolutely malpractice to make anybody an appliance for grinding their teeth until they've had a complete sleep breathing disorder workup, and that that end of story. What do you think of that claim, that it is malpractice to give someone a night guard for grinding They haven't had a complete workup for sleep breathing disorders.
Or you mean one of the things that I mentioned is that sleep breathing disorders on my list of things, but I don't do a lot of that one for this reason. It is really insurance driven, and I don't do insurance. They need to pay me up front before we do them. That's a different conversation in itself, why I do that and all that. And because I don't do a lot of it, but I had a lot of interest in it early on because I do a lot of full mouth reconstruction. When I sedate them with the oral sedation, and I'd done it for many years, long before docs came along, I would often notice people in the middle of the procedure, they kind of stop breathing. And I had to wake them up. And of course, they are being monitored, they're in the pulse ox and everything else. But it made me wonder, how many of these people are stopped breathing in their own home? Nobody ever knows. That is where my interest came from way back when. I'm a member of the American Academy of Sleep Medicine, not a dental sleep medicine. I just want to know about it, be on top of it. To say it is malpractice to put anything in the mouth unless you do full-blown study and then do sleep treatment, I think there is perhaps, in my opinion, overblown importance of their little area. I do many things, including that one. It is true. Anything you put in the mouth can affect. But that's like saying nobody should ever do orthodontics unless they go do a full case of a workup to figure out where the jaw should be. Would that work? Would that be malpractice to do orthodontics or Invisalign if you don't know exactly how the joint is, how the muscles are? That would be analogous to saying that. If you don't do full-blown sleep study, you cannot do a bite guard. To me, is analogous to what I claimed I just made.
You are an amazing man. I could listen to you for 40 days and 40 nights. I mean, is there anything else you wanted to talk about that I wasn't smart enough to ask?
No, you're plenty smart. What else? Well, let me put in a plug-in for ADA. I'm very much part of ADA. I know people complain, bitch about ADA, and this doesn't do that, and that. We all can have our complaints. But that's the only one we have. And we're about 68% or so are members of ADA. And you probably know AMA is somewhere in the teens, not even 20%. Matter of fact, I'm also a delegate to the American ADA House of Delegates. About 5 years ago, I came up with a resolution. All that it said was this, Harvard, very simple. It says there are people that are promoting Army, Navy, and all those kind of things. There are people that are promoting corporate practice. There are people that are promoting public health. Who's promoting private dentistry, private practice? Nobody, right? So all that my resolution asks for is for ADA to spend some effort in promoting this as a model. And I thought I'm doing something good thing. I thought it would be like a motherhood and apple pie. That resolution got shot down at the ADA House of Delegates. It may be, I was surprised to hear that. Like, why would you be against this? Because if the private practice area dies, so does ADA. Because that is exactly what happened with the AMA. Because I was doing study, in preparation for that resolution, I asked AMA, what is your market share? They would not tell me. I said, really? So I called ADA person and thinking the colleagues calling each other, both in Chicago, ADA membership person asking AMA membership person, they thought they'll tell them. They were surprised. The AMA person would tell the person what their market share was, that how proud they are of that one. So we can only go on indirect evidence and so on, somewhere in the teens. Why did that happen? Because private practice went down. There was a time, you probably know this, most docs own their own practices, right? How many of them own their practices these days? Not very many. They are just about all owned by hospital corporations and so on. AMA, to a large extent, many of them they're all doctors, but they don't have private practice doctors. They may work for an insurance company. They may work for hospital-owning corporations, any number of things. I don't want none of my kids went to dentistry. This is not for me. I'm talking about the young kids coming up after us. I want ADA to be the champion to maintain private practice dentistry as a viable option. And we can only do that if we all hang together. We can have our differences, but it is better to be part of the conversation, be part of it instead of paying outside and throwing darts at it. So one thing that I would end with would be become part of your local dental society, dental association, and be part of the solution instead of just complaining about it. So that's what I would end up with. It's not controversial, Nothing to do with TMD, but do with dentistry for sure.
Well, I think it's I've been a due paying member since day one. I always pay my dues,
Me too.
and
Me too.
it's
Well, it's
so
just
funny.
normal those days.
It's so funny on Dental Town. You'll hear someone complain about the ADA, so they'll quit paying their dues. I'm like, dude, you have more complaints about your own parents than you do the ADA. And I mean, I have 4 boys, and one of those 4 doesn't even think I'm perfect. Imagine that.
Hard to know. Hard to believe that.
But so the bottom line is, I mean, when you graduate from dental school, when I was at UMKC, my mom and dad cried. And if you want, I mean, it's a sacred, sovereign profession, and they're the only team fighting for your profession. And if you don't fund and support the only team fighting for dentistry, you're an idiot. I mean, you're an idiot.
Okay.
And the other thing is that there's, I think of the ADA as a very federal part, Chicago for Washington, D.C., but then there's 50 states. You're the president of the 50 states, and these dentists don't know about all the little legislative battles that are going on every day in every state all day long, and they think that doesn't need supported. I mean, there's so many issues, and I was telling, I had my local executive director on a podcast, Kevin Earl, and I was telling Kevin Earl that the only complaint I have about the ADA is that they don't market well enough all they're doing, because every time I have lunch with Kevin, I hear about all the bullshit going on in the legislature, and then I'll be, watching a football game at the bar with dentists, and they don't know any of this stuff. And so the only thing I would say to the ADA is they just got to get a better job of getting out all these crazy battles. And I mean, they're the only ones fighting for you. And I've had a couple of presidents of the ADA on the show, and I've had the executive director on. Who's the current president of the ADA right now?
Gary Roberts. You should get him on. He's a great guy.
Well, fix this up. Email him and CC me, Howard at dentaltown.com, and my son Ryan at dentaltown.com, and we'll move him to the front of the line because, my gosh, if no one's fighting for you, this profession, and the thing that worries me the most as I look at healthcare is if all the dentists work for Wall Street and all the physicians work for corporate, who are Americans going to go to when they need a doctor?
Yeah.
When you're sick, when your baby's sick, you don't want to go to a Wall Street executive. You don't want to go to an insurance salesman. You don't want to go to an MBA. You want a damn doctor who wants to do what's best for your child. And if all the doctors are employees, then what are we going to have to do? Are we going to have to go back, to the Eastern Hemisphere to find a real doctor?
Well, they're doctors. Their decisions are often overseen by somebody else and controlled by somebody else. That's a problem, right? They may have
these kids tell me they work in corporate dental office in America, and an office manager who has she has no training, says that every pocket that's greater than 5 millimeters has to have a perio chip in there, and she can't find one periodontist in her town that agrees with that. And then they say things like, well, 30% of your new patients need perio, and that's like telling a physician that 30% of your new patients have chlamydia. I mean, I thought you only have chlamydia if you have chlamydia. I didn't know that 30% of your new patients had chlamydia. I mean, it's crazy. And that's where I am I'm very skeptical of these laws that non-dentists can own dental offices. Because, who built the first great car? Henry Ford. He was an engineer. You know what I mean? I think the guy in charge of the dental office, I think she should be a doctor of dental surgery. I don't think she should be an MBA from Wall Street.
Now, I'll get a hold of Dr. Roberts, Gary Roberts, good guy. He's from Louisiana, very down home, straightforward, straight talker. It'll be great for you to get together on the podcast.
Yeah, and tell him that the most fun I ever took, I could tell you my Louisiana story, and you wouldn't even believe it. So I went down there and lectured in Lafayette, and I took all 4 of my boys, and then we were done. We drove 2 hours south to where the roads ended, then switched to these flat bottom boats and went, an hour out into the Gulf of Mexico, red fishing. And then we were coming back, we found like a you can't make this stuff up. It was like a 12-foot long alligator, bloated, almost dead. He obviously he got lost to sea. So we tied him back. We trolled him all the way back to the shore. And then my 4 boys were all sitting on him like a horse. And, you know, we're taking pictures of these 4 boys sitting on him like a horse. There must have been, you know, between all the dentist kids, there must have been 10 kids in the alligator. So then we all went upstairs. We cooked fish. We all passed out. Anyway, when we woke up in the morning, that alligator was gone. So he obviously got well enough to crawl off in the middle of the night. But yeah, I love
what a great memory for the kid.
Love to talk to the president of the ADA. Congratulations on being the president of the Missouri Dental Association. Congratulations on being the first non-American born, non-white to be. That's so cool. And I just think that you're the.
The only thing I want to bring that up is there were never any barriers. I want to make it clear. Nobody ever kept anybody else from going to this level. Nobody tried. So to me, one of the biggest thing hopefully I do is just when they see me doing that one, hey, if he can do it, I can too. That's basically, there were no barriers. Nobody went out of their way to recruit us either. It's up to you. So all that I want to make a point of that one is there were no barriers. No one actively recruited somebody that is not white. But now that I'm there, just an example would be like, oh, if he can do it, I can do it. And hopefully that'll bring more people that are, you know, we are mixed ethnicity here. So that'll be only good for the country and good for the association.
Well, thank you for all you do for dentistry. It was wonderful talking to you for an hour. And I hope you have a splendid day.
Thank you so much, Howard. I appreciate it. And I'll get a hold of Dr. Roberts for you.
Okay.
Take care.